Bristol-Myers Squibb. I would like to thank the sponsor for sponsoring this educational activity today. Can I have the next slide, please? Of course, if you have any questions, you can leave your questions in the Q&A box, so we can take your questions by the end of the presentation.
Can you reshare your
Sure, I'll share from my side. So we're going to talk today about new era in large B-cell lymphoma, pushing the frontiers of care with CAR T-cell therapy. As I mentioned, this activity is sponsored by Bristol-Myers Squibb. And this is our agenda today for the webinar. We'll start by Prof. Riyad Al-Faqih. He's a professor of medicine at Al Faisal University, and he is the chairman of clinical trial management department at King Faisal Specialist Hospital and Research Center in Riyadh. He's also a consultant of stem cell transplant, hematology and stem cell transplant at King Faisal Specialist Hospital. He will talk about the evolving role of cell therapy in large B-cell lymphoma management, and then followed by Dr. Sayyid Osman. He's a consultant in hematology and stem cell transplant at King Faisal Specialist Hospital Research Center in Riyadh. He will talk about the management of toxicity associated with cellular therapy in large B-cell lymphoma. So as we witnessing the evolution and the expansion in novel therapy in all aspects in hematology, relapse refractory large B-cell lymphoma now become a challenging task to choose between available options. However, there is a lack of, I would say, head-to-head comparison between these novel agents. Comparative trial are lacking to compare this novel agent. However, real-world data can actually help to bridge the gaps between these agent and the gap in the knowledge that's help to make better decision what agent we can choose for our patient population. It is now well established that the second line treatment for relapsed refractory lymphoma for patients who are eligible to receive the CAR T-cell therapy is now well established to use the CAR T-cell therapy for this patient population. Today we will learn who are the patient population who are eligible to receive this kind of treatment with our eminent speakers. So without further ado, I would like to introduce Prof. Riyad Al-Faqih to present his first talk. Prof. Riyad.
Thank you, Dr. Badr. Thank you, SSBMT and BMS for sponsoring this talk. Going to share my slides now. You see my slides or?
Not yet.
Okay.
Doctor,
Yeah.
you may proceed. It's shared already.
We can see it.
Well, the problem, I don't see the slides. So let me see. Oh, that's it. Okay, so you can see it now, right?
Yeah.
All right. So again, thank you for hosting us today. And my talk is about the evolving role of cell therapy in large B-cell management. I'm going to turn off my camera. Maybe the connection is not the best in the office. So slide not moving.
Doctor, can you please reshare your presentation? I'll stop the sharing and
Okay.
please reshare it.
Okay. All right. Moving now, right?
Yes.
All right. So these are my disclosures. And this is my agenda. So I'll go over an introduction, talk a little about the registration data for different CAR T-cell and large B-cell lymphoma, and touch base on the upcoming development and the new research in large B-cell lymphoma cellular therapy. So here you can see the split of different non-Hodgkin lymphoma, and you see the larger population is the diffuse large B-cell lymphoma, then comes follicular lymphoma. We do have CAR T-cell in the clinic for large B-cell lymphoma, for indolent lymphoma, and mantle cell lymphoma. Focusing on large B-cell lymphoma, 3 products are approved: Axi-cel, Tisa-cel, and Liso-cel. Axi and Liso have labels in the second and third line, Tisa-cel only in the third line and beyond. Here you can see the pivotal trials for the third line setting, third line and beyond. So that's where these cells were tried initially. And you see they have similar curve with flat curve, around 35 to 40% possibly cure rate, with difference in the overall response, CR rate, and toxicity profile. But basically, the long-term data is pretty much similar. This is comparing trial to trial, not head-to-head. When these therapeutics succeeded in the third line, the next step was to move them to earlier lines. So these are 3 trials that were done in the second line, focusing on high-grade or high-risk diffuse large B-cell lymphoma. And these were defined as patients refractory to frontline or relapsed within the first year after frontline treatment. And the 3 trials are ZUMA-7, Belinda, and the Transform. Here you can see the results. So this is the ZUMA trial, and you see compared to the standard of care, salvage and O2 CAR T-cell did better. This is the Transform trial. Also compared to the standard of care auto transplant, Liso-cel was better. And the Tisa-cel trial was a negative trial, and as such, Tisa-cel is not labeled in the second line. Here you can see the longer follow-up in the second line for the Liso-cel versus standard of care. So this is Liso-cel, this is salvage and auto standard of care. And you see the PFS is 52.2% at 4 years for the Liso-cel after a median follow-up of 49 months. You can see here the toxicity, CRS 49%, but only 1% grade 3. Neurotoxicity 11% all grades, and only 4% grade 3 and above. And you see the overall survival rate 61.5%. This is the Axi-cel, the ZUMA trial in the second line, also long-term follow-up, the 5 years follow-up. And you see the PFS is 42%, the OS is 55%. The toxicity is higher here. You can see the CRS 92% with 6% grade 3 and above, neurotoxicity 60%, grade 3 and above 21%. So because there are no head-to-head trial comparing Axi-cel to Liso-cel, real-world data comparing these 2 options were published from different groups. Here we can see the French registry. So the DISCARD registry is a large French registry. And in this trial, they compared Liso-cel to Axi-cel in the second line diffuse large B-cell lymphoma. You see here the baseline characteristics. So patients in the Liso-cel were older, 71 versus 63. You see here high-grade B-cell lymphoma, 6% in Axi-cel versus 2% in Liso-cel. Primary refractory, 76% in Axi-cel versus 67%. LDH was similar, and performance was worst performance status was less in the Lysocell group. You see 22% of patients had ECOG 2 and more versus 11% in the Axicell. Here you can see the overall response rate. So this is Axicell, 78%, and complete remission 64%. Lysocell 86.5% overall response rate and 68.5% complete response. PFS is similar. You don't need a statistician. You see the curves superimposed. Overall survival similar as well. So basically, same efficacy, a little bit more overall response rate with the Lysocell, but not statistically significant. When it comes to toxicity, there is a difference. So here you can see Axicell in gray and Lysocell in blue. And here you can see the p-value for these different toxicity. So any grade CRS was higher in Axicell, 89% versus 49%. Grade 3 and above was also higher in Axicell. Any grade ICANS was 53% versus 9%. And grade 3 and above 19% versus 1%. ICU admission was higher as well in the Axicell. Non-relapse mortality 6.3% versus 2.2%. And progression or progression-free similar in both. So basically, real world comparison, same efficacy and toxicity is in favor of Lysocell. This is a real world US study, so 15 US centers looking into Axicell versus Lysocell. This trial or this study had second line and third line patients. The majority were third line, but it did have second line patients. Here you can see also the median age is higher with the Lysocell, and the other distribution are pretty much similar in between both arms, except for the vein-to-vein time, where you can see it's longer with Lysocell, 12 days more with the Lysocell, and the out of specs, 13% with the Lysocell versus 3% in Axicell. Here you can see the overall response rate for the second line, and here for the third line. So you see for Axicell, 65% overall response rate, CR 58%, for Lysocell, 78% overall response and 69% complete remission. Here in the third line, you can see also the same trend. On this side, you can see the toxicity. So blue is grade 3 and above, and orange is no toxicity. You see in the Lysocell, the majority did not have toxicity, and less than 1% had grade 3 and above CRS versus 13% in the Axicell. And for the ICANS, as you see, around 80% did not have toxicity in Lysocell, grade 3 and 11% versus 20% in the Axicell. So basically, the real world data is similar to the trial data. Here you can see also the PFS in these US patients, and it's similar. Overall survival is similar in between both. So basically, similar efficacy and a trend for better toxicity profile for Lysocell. Here you can see the overall response rate and CR rate, so both crossing the midline, no statistical significance. And here you can see the duration of response, PFS and OS, similar as well in both treatments. Now, when you look into toxicity, and this is a meta-analysis, large group of patients, 2,200. So you see this is favors Lysocell from different trials when it comes to CRS, and this is favoring also Lysocell with all the trials, and this is when it comes to ICANS. So again, trials, no head-to-head, but comparing trial to trial, same efficacy, less toxicity with Lysocell. Real-world data reflecting the same, and this is a meta-analysis also reflecting the same. The other thing I need to point out from real-world data, and I don't know if that reflects in Saudi Arabia, probably our rates are better. So basically, in this real-world exercise by Perales, what they showed is the fact that only 25% of patients eligible for CAR T-cell end up receiving CAR T-cell in the second line versus 75% dropout rate. I don't think in Saudi Arabia this is similar because we have an efficient referral process, and we may have a problem with referring all eligible patients, but the referral process is very efficient. So CAR T-cell provides a potential for cure in large B-cell lymphoma, and many patients eligible are not receiving this effective therapy. Also, the data shows that the use of CAR T-cell in earlier lines is associated with improved outcomes. So what's upcoming, what's new or come to the clinic in the next few years in cellular therapy for large B-cell lymphoma? Here you can see the ALPHA3 trial. So this is an allo cell, allo CAR T cell, and it is tested for in minimal residual disease state. So this is an interesting concept. Frontline patients with positive MRD treated with allo cell and basically trying to clear up the MRD and cure these patients who are at very high risk for relapse. Novartis has a similar trial. This is the YTB323 reptacaptid gene autoleucel. So this is autocell for MRD positive large B-cell lymphoma, and we're working with them to open this trial in our site. Frontline use of CAR T-cell. So ZUMA-12 was axi-cell in frontline for the high-risk B-cell lymphoma, not across the board. And because the results were as expected and good enough, Kite decided to do the ZUMA-23, which is a frontline randomized trial looking into CAR T-cell in the high-risk large B-cell lymphoma. So this trial is ongoing, and we expect results soon. The other development is allogeneic CAR T-cell. As you know, autologous CAR T-cell need significant logistics. So allo CAR T-cell can resolve many of these and can be off-shelf, so available immediately to treat these patients. Here you can see different products, and basically the gene editing is different in between the products, as well as the targets. So some CD19, and here you can see this is CD20. Basically, the allo cell is an interesting concept because, again, it's off-shelf. The problem is persistence of these cells and long-term efficacy because these cells can be rejected by the recipient immune system. The most advanced one is Vispacell, and Vispacell is starting a phase 3 trial. Also, we're trying to open this trial in our center. It's called Antler-3. So this is Vispacell against investigator choice standard of care. Again, allo cell and second line diffuse large B-cell lymphoma. All the products available in the clinic today are targeting CD19, but dual targeting is another concept. So targeting two antigens, because basically the lymphoma cells and like any cancer cell can escape, the CAR T cell by becoming CD19 negative. So the concept of dual or triple targeting is to target many of these antigens in order to avoid negative relapses. So here you can see the CD19-22 targeting 19 and 22 in large B-cell lymphoma. You see a large amount of trials from different groups. We don't have time to go over it, but basically, again, it's the concept of decreasing negative relapses. Here you can see the CD19, CD20 dual targeting cells. And you see also 4 groups are working on these cells. Basically, same concept, targeting 2 antigens to avoid antigen negative relapses. Kite also has a product. So the The Palisade-2 trial is being activated in Saudi Arabia, and our site is one of the sites. So this is a phase 3 randomized trial comparing Axicell versus the Kite 753 product, which is a product produced on a rapid production platform and targeting CD19 and 20 in the second line for relapsed refractory patients. Different targets are also being evaluated, so it's not only CD19, 20, and 22. Here you can see the BAF CAR T cells. So BAF antigen is expressed on many B cell malignancies, including lymphomas as well as myeloma. And you see this is a phase 1, and this is another phase 1 from Luminary Group. And Luminary Group is also trying to open a phase 2 trial in Saudi Arabia targeting both large B-cell lymphoma and multiple myeloma. In vivo CAR T cell, in vivo will be the revolution. So if this succeeds, because here you don't need to ship cells in that out, and it's not allogeneic, you don't need bioreactors, you don't need GMP facilities. The patient himself will be the GMP facility. Also, you don't need lymphodepletion. Now, there are many regulatory problems with this process, but if this succeeds, it'll be a game changer. And many companies are investing big time in vivo CAR T cell. You see here the LB product, Legend Biotech, is already in clinic for relapsed refractory B-cell lymphoma, and it's a dual in vivo CAR T cell CD19, CD20. You see here the overall response rate is 100% with 83.3 CR rate. And this is again without lymphodepletion, without clean rooms. This is in vivo. This was published on June 15, so a few days ago. The other concept, again, because autologous CAR T cell, you need to collect cells, send them abroad, bring them back, is decentralized production. So this is like opening, clean rooms, point of care clean rooms where you can treat your patient in your hospital. So we do have point of care CAR T cell decentralized production. We treated 2 patients for acute leukemia, not for diffuse large B-cell lymphoma. But here is what's happening in diffuse large B-cell lymphoma. So you see Zemtacap2 gene is a dual target CD19, CD20, and it is finishing. It did finish phase 3 studies. Now will undergo regulatory approval. And it's a challenge how to regulate these cells, So if they give them a label, then how about producing in different sites? So probably the production will be central. And although the trial was decentralized, but this is interesting to see what happens. So in summary, CAR T cell showed impressive results in refractory lymphomas, myeloma, and ALL, and real-world evidence reflect similar trial results. Early referral and multidisciplinary evaluation are keys for better outcome. CAR T cell is a standard of care in second line in large B-cell lymphoma. Frontline studies are ongoing. MRD studies are coming soon. A lot of innovation happening, different platform, different targets, and including in vivo platform. So the pace is rapidly changing, and you need to be careful when you choose which way to go. Many challenges still exist as of now. The cost is the major challenge. Access, again, because all the approved products are centrally produced. Manufacturing time is being tackled, and soon we will have very rapid production times. Toxicity is still problematic, and many of the new CAR T cells are focusing on reducing the toxicities. Post-CAR T relapse, I would say, is one of the highest unmet needs in the clinic. When you treat these patients and the disease comes back after CAR T, your options are very limited. We do have biclonals and other forms, but unfortunately, the efficacy is very limited after CAR T cell relapse. With this, I will finish, and I don't know if the questions are at the end, so I'll.
All right, thank you very much. Thank you very much, Prof. Riyadh. This is an elegant talk, and so we'll actually leave the question until the end. I would like to remind our attendee that the Q&A box is available. You can put your questions there. And now we'll move on to our next topic, and presentation will be presented by Dr. Saeed Osman. And he will talk about the toxicity following the cellular therapy in relapse refractory large B-cell lymphoma. Dr. Saeed.
Thank you very much, Dr. Badr. Bismillah wa salatu ala Rasulullah. Thank you very much for the invitation. Thank you very much to BMS for organizing this, and thank you, Dr. Badr, and thanks Riyadh for that talk. Okay, I'm going to talk a bit about the toxicities of CAR T, and specifically large B-cell lymphoma, or I perhaps have a bit of interest with colleagues. There you go. Okay. So we know that T cells are very active. We've heard that from Riyadh's talk. They help in immune surveillance. We use it in transplants all the time with DLIs to elicit a GVL effect. Their use is harnessed in checkpoint inhibition and also in bispecific engagers, and now in CAR T cells, obviously. But as we heard, and as we know, the potency of T cells needs to be harnessed. And CAR T cells do not come without their toxicities, and we'll go through some of these, especially CRS, ICANS, and some of the later toxicities. Now, before I do that, I'd like to share a bit of an anecdote that I was kindly sort of associated with, because we looked after some of these patients, and it just highlights the risks of immunotherapies that are not harnessed. And this is a Northwick Park Hospital near Wembley in the north of London, where in 2006 they ran a trial. T. Gennaro ran a trial of a super antibody in a number of healthy volunteers. And a few days after the trial ran, these were the headlines in the newspaper, so it was frontline news, that 6 healthy young men on a phase 1 trial became sick very quickly, and they ended up in ICU. They all survived, but some of them had their toes amputated, some of them developed lymphoma, and T. Gennaro collapsed. So that put a break on a lot of immunotherapy development. And we also know that in the cell and gene therapy field in itself had faced lots of setbacks. Then we had this story of this young girl, Emily Whitehead, who, again, this was a headline, whose cancer was cured by HIV. But we know that when she was one of the 2 patients that was initially reported by Steve Grupp in New England Journal of Medicine, we know that these 2 patients also had the sort of cytokine storm that the previous immunotherapy trial patients had had. And this complication almost placed the development of CAR T cell on hold, because these girls were in ICU, and as you can see, they had a high temperature, and they had this elevation in their LDH, and they went onto pressors, and they were doing cytokine profiling. And as you can see over here, the orange curve is interferon gamma, and the black peak was IL-6. And this is what sort of perked the interest of Steve Grupp and Carl June to say that maybe we can target IL-6 with tocilizumab, and that's how tocilizumab got approved along with the CAR T cell therapy. So we know now that up to 90% of patients getting CAR T can get CRS, up to 60% can get neurotoxicity. And it's very important that there are clear pathways as to how this is identified and how it's managed. We have to have a multidisciplinary approach. We need to educate and train people about it, and we need to ensure that we're managing this appropriately. This is a door on our CAR T BMT ward. We put the guidelines in the table on the door so people know what to do at 1 a.m. So what is cytokine release syndrome? It has been defined as a supraphysiological response following any immune therapy that results in the activation or engagement of endogenous or infused T cells or other immune effector cells. So hence why we have an algorithm for CRS following bispecifics, for example. So symptoms can be progressive, but they must include fever, And they may include hypotension and capillary leak leading to hypoxia and end organ dysfunction. And it usually occurs in the first 2 weeks, but it can rarely occur later, but most CRS occurs early. And this was a very nice review from Emma Morris and Madeleine, Michelle Sadelaine, not Madeleine, in Nature Reviews, that sort of gives the chronology of CRS and ICANS. So as you can see, CRS occurs in the days, usually in the 2 to 3 days after the infusion of CAR T cell therapy, and ICANS occurs later. And almost all, so not everybody who gets CRS will get ICANS. Not all patients get ICANS, but almost all patients who get ICANS would have had a prior CRS. It's very, very exceedingly rare to have ICANS without a prior CRS, and which is why many would consider this a different manifestation of the same underlying physiological process. That also corresponds with the expansion in T cells, which, as you can see, actually happens. So this sort of illustrates the point that you don't need many CAR T cells in the circulation to actually elicit this reaction. And whereas the expansion in CAR T cells may sort of lag behind some of the manifestations that we see, the cytokine release is relatively early. And as you can see, you have this early peak that includes interleukin-1 beta, interleukin-1 receptor alpha, GM-CSF. And this is why there's always been some concern about giving GCSF, but mainly the issue is with GM-CSF. But also interleukin-2, interleukin-7, and IL-15. And obviously IL-6 plays a major part, though it may occur just slightly after the peak of the interleukin-1, 2, and 15. IL-6, IL-8, IL-10, interferon gamma, and TNF-alpha, their levels rise a bit later. And the important thing to realize is that, and this was also demonstrated by the team of Michelle Sadelaine, that the effector cell in CRS is not directly from the CAR T itself. It's not the CAR T cell or the cancer cell that releases the direct mediators of CRS, but actually it's the activation of the bystander macrophage monocyte system. So the macrophages get activated, hence the concern with GM-CSF, because you may inadvertently activate those macrophages. And that leads to recruitment of other monocytes, and that leads to release, as you can see here, of IL-6, IL-1, nitrous oxide, and other mediators of inflammation. And this is what leads to the cytokine release, the vascular leakage, the hypertension, and the other manifestations of CRS. And again, this study was a preclinical study that demonstrated the centrality of interleukin-1 and why interleukin-1 blockade, say, for example, with anakinra, can ameliorate the symptoms and signs of CRS and ICANS. How do we grade CRS? It is, and ICANS and neurotoxicity, it is through this consensus grading system from the ASTCT that was published in 2018. So prior to this, a lot of the grading was through the CTCAE. So there could be disparity in how subsequent studies were graded, or how we may grade toxicities now compared to how they may have been graded in the early trials prior to this publication. So this is an algorithm. This is what we have on our doors of how we manage CRS. So again, the first thing to do, as we know, is to grade it, whether it's a fever. You have to have a fever to define it as CRS, and then whether or not there is hypotension and or hypoxia, that determines the grade. Tocilizumab is not usually given in grade 1, but it could be given if it's persistent beyond 24 hours, or there may be a lower threshold for giving tocilizumab with Axicel or Broxicel because of the high risk of toxicity. And steroids aren't usually given therapeutically in grade 1, but they may be given prophylactically for Axicel. Again, grade 2, here you certainly do need tocilizumab. Grade 3, you need tocilizumab and steroids, and here you're talking about ICU territory when patients are requiring pressors or high flow oxygen. So what are the risk factors? Patients who are older may have a high risk of CRS, but certainly higher disease burden, higher CAR T cell dose, and the lymphodepleting intensity, especially with fludarabine. All of these are risk factors for CRS. But an important aspect is the product, whether it's whether the co-stimulatory domain is a CD28 or a 41BB with like Axicel, for example, the CD28, there's a more robust early expansion, so it's more likely to cause an early and more severe CRS, as opposed to the 41BB containing CAR T constructs. So here is a table of some of the toxicities in NHL studies. So for example, this is the Pasquini real-world Tisacel study, CRS 45%. This was again Tisacel from the Schuster, the registration study, or close to 60%. Again, the highest rates are with Axicel, whether it was the Zuma 1 study, 93% total CRS, or the Zuma 7. And the lowest rates are with Lysocel. So this is the risk of CRS across studies for NHL. These are some of the studies. These are ranked not in order of overall CRS, but in order of most severe CRS, grade 3 to 4 CRS. Now, we know that Axicel has the highest risk of CRS. And we often say that Tisacel has a lower rate, but this is a Schuster study of Tisacel. Yes, the overall rate of CRS was about 55 or so %, but they did still have a significant rate of grade 3 to 4 CRS. Now, I just here like to highlight our own results that are in green. So on the left is our CRS rates with Tisacel, work done by Dr. Rima Lasbali and Ali Al-Ahmari that was published as an abstract. So as you can see, even with Tisacel, you get a fair amount of CRS. This is the publication that was out in Cytotherapy this year from Khalid Hibani, Abdulwahab Babtain, and colleagues. So as you can see, there is almost 90% CRS higher in the third line setting. And you can see that the top line over there, the dark bit over there, is the severe CRS. So interestingly, perhaps we haven't seen the kind of severe grade 3 CRS with Axicel in our population as in the published cohorts. But again, what you see here is the lowest rates. This is Pasquini's real-world data. Again, this was lower than the registration study. But again, Tisacel is sort of going out of favor for NHL. So in terms of sort of the candidates that we would use, these are the outcomes for CRS with Lysocel. This is the Abramson study, the Transcend and the Transform study. Again, very low rates of severe CRS. Moving on to neurotoxicity and the neurological toxicity of CAR T cells, again, up to 60% of patients can get them. That's what ICANS stands for, immune effector cell-associated neurotoxicity syndrome. And these are some of the clinical features that can be seen. Speech problems, impairment of cognitive skills, motor weakness, dysgraphia, so that's why we ask them to write. They may get a tremor. They may just get a bit confused, but obviously in the most severe form, they can get seizures and cerebral edema. Again, if we look at neurotoxicity across studies, the highest rates of neurotoxicity in the most severe forms are with Axicel. Interestingly, we saw maybe less severe ICANS than would have been expected in our cohort that was published by Khalid Hibani, but there still is significant proportions of patients who get severe neurotoxicity. And again, this is the so Tisacel does cause less neurotoxicity than Axicel, but again, the problem there is that's offset by the lower efficacy rates. So in terms of efficacy, we have Lysocel, lower rates certainly than Axicel. So what are the clinical features that predict increased risk of ICANS and neurotoxicity? Age, so older patients are at higher risk of neurotoxicity, more prior lines of therapy, bulky disease, high LDH. Some studies suggest prior CNS disease can lead to increased risks. Prior CRS, as we said, more severe CRS is associated with more severe ICANS. And there are certain biomarkers such as CRP. You always have to think of fludarabine toxicity when we see neurological toxicities following CAR T, but that tends to occur much later, and it's quite rare. So one question that often comes up is this: is it the CAR T cells per se that are causing the neurotoxicity, or is it something else? Because almost all patients have tracking. You can detect in over 90% of patients, you can detect tracking of CAR T cells in the CSF. And that is why it's also shown efficacy in patients who have secondary CNS lymphoma without an increase in toxicity. So we know CAR T cells track. So is it the CAR T cells tracking? Is it the cytokines? Is it both? So if we were to bet on one, what is it most likely? So there was an early study run by Juno, which was a rocket study, which had to be halted because of fatal cerebral edema and fatal neurotoxicity. And that gave us some clues. So what they found cerebral edema. They found a perivascular infiltration of T cells and macrophages. They had some leptomeningeal accumulation of CAR T cells, activation of microglial cells. There was a complete breakdown of the blood-brain barrier, and a lot of edema. But what was highlighted by Daniel D'Angelo is it wasn't what they had expected. They had expected a lot of CAR T cells within these areas that were causing the actual toxicity, but it wasn't. It was other immune cells that were infiltrating the brain. And what appears to happen is when you get CRS and you have that breakdown in the blood-brain barrier after activation of T cells, the cytokines, as we said, break down the blood-brain barrier, and it is the cytokines that surge in the CSF that activates other cells, stromal cells, so microglial cells, astrocytes, and that leads to the neuronal dysfunction. So it seems to be that it isn't the CAR T cells per se, but it is more the cytokines that diffuse into the CSF that cause the secondary damage. And CAR T cells contribute, but they're not the primary contributor. So again, this is how we grade ICANS, again, based on ASBMT and ASTCT grading. This is, again, our wall poster. So the first thing that has to be done is first you calculate the ICE score when we ask these questions, and we make a score out of 10. Then we determine the ICANS grade. So based on the ICE score, so if the ICE is sort of 3 to 6, then it's grade 2. But we also do it on the basis of the worst other features. So for example, if a patient is having prolonged seizures, you won't be able to get an ICE score, but that's ICANS grade 4. Or if there's deep focal motor weakness, such as hemiparesis, and even if the patient's speaking normally and the ICE score is sort of 6, 7, or 8, you do grade it by the worst neurological or motor finding. Again, this is our algorithm based on whether there is or isn't concurrent CRS, which is available from the reference I mentioned. Now, one thing that we mentioned about the type, so we mentioned that neurotoxicity and CRS depends on the kind of construct that you use. So, and in the 3 players, or the main 2 players at the moment, for non-Hodgkin lymphoma, liso-cel does cause less toxicity. So this was a study where they looked at 627 patients from the Cell Therapy Consortium in the US, and they found that, but this was presented by Bachanova. They looked at patients who'd received axi-cel, liso-cel, and tisa-cel, and they defined toxicity-free CR at day 100, and CR with toxicity at day 100, and toxicity-free progression-free survival at day 100, and this is how they defined it. And essentially what they found is that what we know, axi-cel had comparable responses, liso-cel was slightly better, but the toxicity-free PFS was much better with liso-cel. 70% versus 46%. And in terms of toxicities, you can see over here, grade 3 toxicities were 5% with Axel. You didn't have any grade 3, 4 toxicities with Lysocell, and any grade CRS was lower. Any grade ICANS was lower. So if you want a product which is less toxic, then Lysocell is certainly less toxic than Axicell. And this was the overall survival and byproduct. So similar, but less toxicity. Here you go. So we do know, as we said, that even from another study, that Lysocell shows a more favorable toxicity profile. So, but beyond that, there are some emerging constructs and CAR T cells that are coming. So, for example, one trial that we hope to be running here soon, which is an ultra-fast CD19 from Curacell company, and that's manufactured in 24 hours. And that's so far shown a CR rate of close to 88%, with a diminishing low severe CRS or neurotoxicity rate. Also, Varnicell, which was the construct co-developed from Barcelona, then out-licensed to India. Again, they have a relatively low severe CRS rate, 4% and 5.9%, and a very low neurotoxicity rate. So there are more emerging agents coming. So, how can we predict CRS or ICANS or cartopenia? So we know that there are multiple factors: patient factors, product factors, disease characteristics, and then there are certain biomarkers. So one thing that we're trying to look at is to see if we can predict these by looking at biomarkers and cytokines, and try to predict the progress or toxicity of the patient's side effects. If we can predict that earlier, then we can prevent it earlier, or we can preemptively treat, whether it's with steroids or with earlier tocilizumab or with anakinra. So what we did find is, this is what IL-6 find. This was in ALL patients. This is what we find IL-6 traces look like in our patients following Tisacell, for example. And as you can see, there's this early peak, and then there's this late peak that happens as well. And these tend to be the patients who progress then to HLH. And what we tried to figure out is whether it was a peak IL-6, or whether it was an early IL-6, or whether it was the IL-6 area under the curve that was most predictive of the grade of CRS. And we found, and this was work done by one of our medical students, this was presented in ISTCT. We looked at these different biomarkers, IL-6, ferritin, and CRP, and tried to predict using a Spearman correlation if you can predict toxicity. And in terms of correlation, though the correlation was weak, there was a trend suggesting that it was the peak IL-6 that predicted the severity of CRS, while it was the duration of IL-6 elevation that seemed to predict ICANS severity. Again, these were weak correlations, but it gives you some trend. We did the same for looking at Tisacell, and this was done by Ms. Hanan Al-Qaderi from the research lab. Again, in terms of CRS severity for B-cell lymphoma, it was there was IL-6 area under the curve, IL-6 peak and duration all seemed to predict that, so you couldn't distinguish between them. For ALL, they seem to be trend toward IL-6 area under the curve and IL-6 peak. These were some of the correlations for B-cell lymphoma. So it seems to be, without going into too much detail, it seems to be that the IL-6 peak seems to be more predictive of the onset of severe CRS. But again, it is a weak correlation. We need to do more work. I won't go, so I'll just quickly skim over some of the other late toxicities. So we often talk about CRS and ICANS being the main toxicities, but infections, almost all of these, a vast majority of these patients will get fevers, and we should not forget that the CRS, often we treat with steroids and anakinra, but we need to not forget that these patients may have infections, and we need to, in parallel with our CRS algorithm, follow our febrile neutropenia algorithm, with repeated cultures. If there's a persistent fever beyond 96 hours, do a CT scan for invasive fungal infection, do blood cultures, look for infections, especially patients who have prolonged CRS, or the ones who go into HLH, or the ones who have the more severe CRS, and you end up giving them lots of steroids. So those are the patients particularly at highest risk of infections. So ICAT is another sort of subacute toxicity, and various factors may contribute to it: underlying disease, the inflammatory milieu, the baseline marrow reserve, prior lines of therapy, and the bridging radiotherapy that we may give. And there are some postulated mechanisms: the hematopoietic reserve, the imbalance in immunomodulatory cells, and local inflammation in the bone marrow. I won't go into detail, but there is the guideline of how to grade it, and that's the ICAT grading. And in most cases, these patients recover. There's a quick recovery, but then the worrying patients are these ones in red who have an aplastic phase. Again, liso-cel does seem to have a numerically lower rate of severe cytopenia. So if we're considering patients who might be at high risk of cytopenias. Infections, infection prevention is evolving. So the risk factors for infection are pre-CAR T factors and post-CAR T factors. So again, patients, ECOG is very important and maybe sometimes doesn't get measured as well as it should be. So baseline ECOG, number of prior lines of therapy, history of recent infection, adult patients in a low neutropenia, low ANC count, then post-CAR T factors, so severe cytopenia, B-cell aplasia, and a severe hypogammaglobulinemia. And not to forget this, especially in patients who've had prolonged ICANS, the high doses of prolonged steroids, and that also contributes not only to morbidity, also to mortality. So it's classified into 3 categories. The ICAT early infections are early, late, and very late. I'm going to skim over the viral infections, but again, patients should be evaluated for ICAT and infection risk to guide appropriate management using the CAR hematotox score and considering risk factors for cytopenias post-CAR T-cell therapy. Secondary malignancies have been cited and are a concern, but this is the EBMT EHA go-cart statement to say that, yes, they have been reported, but they are diminishingly low. We need to continue to monitor and register these patients, but it shouldn't stop us from continuing. Obviously, it is built into consents, and it should be that patients should be aware of this risk, and that's why you need to register. I'll skim over this, but just to say that 4.3% of patients were found to have secondary malignancies, and myeloid and T-cell neoplasia were more frequently reported. And again, the myeloma patients, as you can see, the ones who had cilta-cel, seem to have been the ones who were most affected. Non-relapse mortality, just as a last section. So this is a study of non-relapse mortality following CAR T-cell therapy. The highest is in patients with mantle cell lymphoma, followed by multiple myeloma, large cell lymphoma, and indolent lymphoma. As we talked about infections, so 50% of these deaths were due to infections, and then followed by malignancies and cardiovascular events. So if we break it down here, again, as you can see, infections, and these are the infections. When this study was done, COVID was active, so a lot of them had COVID, followed by bacterial, fungal, and viral infections. And these are the malignancies, MDS, AML, and in terms of organ failure, it was respiratory failure. So, you know, non-relapse mortality is real. It's important to carefully select patients. It's important to identify patients who may be at high risk of certain complications and try to prevent them. Use the least toxic CAR T if you can get to the same efficacy through that route. And we need to be vigilant to these. Again, liso-cel was associated with the lowest non-relapse mortality among CAR T-cell patients receiving CAR T for diffuse large B-cell lymphoma, and this was from the Nature Medicine paper. And again, given that in terms of toxicities, ICU admissions tend to be lower with liso-cel compared to axi-cel, for reasons that are obvious that we mentioned. And I think with that, I'll end, and thank you very much.
All right, thank you, Dr. Osman. This is an excellent presentation highlighting the toxicity and the pathophysiology behind these toxicity. Let's move on to the Q&A session. I do have some questions here. We'll try to take a few of them because we are almost on time. My first question for Dr. Riyadh, I think kind of summarize what most of the question talking about is, since the data you presented, the equal efficacy between like, let's say, Axicil and Lysocil, and how confident the safety profile of these product like Axicil and Lysocil influence your decision whether which one you choose, whether Lysocil or Axicil?
Sure. So the choice is always multifactorial, and you need to look at it from multiple angles. And you have efficacy, you have the tumor, you have the patient age, performance, comorbidities, the cell itself and its impact, and you have the production time, the production failure, out of specs. So you always have to put together all of these to make a decision. It's never one angle, one decision, but let's assume everything is the same, patient, whatever. It seems like from real world, from comparing trial to trial, Lysocell is less toxic. So, and this is a common concept among all CAR T-cell physicians. Lysocell less toxic and gives you the opportunity to treat, older patients, with more comorbid patients. But again, the decision is usually multifactorial. It's not, only toxicity. It's one essential. Toxicity is essential to make decision, but not is the only one.
All right, thank you very much. Dr. Said, I have a question for you. How do you see infection risk management evolving as center gain more experience with CAR T-cell?
Yeah, so I think, first of all, collaborate with your infectious diseases team. That's what we did. Remember, a lot of these, and one thing is, yes, collaborate with your in ID team. The second important thing is, assess your bioreactor, evaluate your bioreactor. Your bioreactor is your patient. So get clues from the patient's history, the patient's prior positive cultures, resistance patterns in organisms, but also something that we, don't often do is check immunoglobulins, check lymphocyte subsets. If you're starting with a patient who's been heavily pretreated, with a low CD4 count, they've already had a run in to the ICU. So, it's really important to customize your management to your patient and be vigilant of patients who are at high risk of infections. Important thing that I mentioned and re-emphasize is a lot of times we get obsessed with the CRS algorithm and we say, all right, steroids, patient still febrile, all right, anakinra, et cetera, but then no one's done another blood culture, or we haven't checked for a fungal infection, or we haven't done an aspergillus or galactomannan, for example, or we haven't checked for CMV, etc. So those are some of the things I would mention. Have close liaison with ID. Evaluate each patient individually for their risk of infections, and be vigilant for emerging infections, as I mentioned, and follow your sensitivity patterns. I think that's really important for institutions. If 60-70% of your Enterobacteriaceae are resistant to cefepime, then don't use cefepime as your first agent in your febrile neutropenia pathway for CAR T patients, for example. So develop an algorithm. So we also give pentamidine and IVIG, for example, prior to infusion. We use carbapenem first line. We use caspofungin as prophylaxis for reasons that we mentioned. We have heavily pretreated patients. So those are just some points about how to approach and prevent infections.
All right, excellent. I think because of time, I'll have one more question for Dr. Riyadh. I think there's a question about there is a globally there's trend toward less intensive monitoring and earlier discharge for selected CAR T-cell patient. Do you anticipate these practice being adopted in Saudi Arabia? Probably it's talking about the consideration for outpatient use of CAR T-cell therapy. What's your intake on this, Dr. Riyadh?
So if you know, the question intent is for outpatient use, definitely it's, you know, I would think it's in the favor of the patient, of the center, decreasing the bed capacity, you know, and improving the flow of patients. But you have to have the setup. We've been trying in our center, you know, and we haven't succeeded to set up, you know, a stringent outpatient follow-up when you discharge these patients early, or when you do the CAR T-cell as outpatient. You know, we do auto transplant as outpatient. You do it as well in National Guard. But CAR T-cell, you know, ICANS and CRS at home, we're still, you know, trying our best. We're trying wearable now, you know, to see if that helps. Of course, when you bring less toxic CAR T cells, this is can make life easier, and you know, you may select a good number of patients to start with low risk for toxicity, with a lower toxicity cell, and then see what happens.
All right, thank you very much. There is so many questions in the Q&A, but because of time, I would like to apologize for the audience, and I would like to conclude our session today. Thank you, Prof. Riyadh, Dr. Saeed, for the wonderful presentation and discussion tonight. Would like to thank our attendees for joining us tonight, and thank you to the sponsor for sponsoring this educational activities, Bristol Myers Squibb, and thank you to the SSBMT to arranging this weekly webinar. Wish you all the best, and see you in the next webinar in the near future. Thank you very much, everyone.
Thank you.
Thank you. Shukran.
Salam.